I'd also wanted to acknowledge the traditional owners of the land that I'm on. So I'm living in Canberra these days. That's the Ngunnawal and Ngambri people, and pay my respects to their elders, past and present and emerging. And also like to extend that same acknowledgement to the Wadawurrung people, because I lived in Ballarat for the majority of my PhD. So spent most of my time on their land. Yeah, I guess I'll get started. Just, I guess, a content warning that I will be talking about the removal of Aboriginal children. And yeah, I guess if at any point throughout this presentation things come, I guess, overwhelming or difficult to listen to, please feel free to, mute me or leave the meeting and do whatever you need to do to take care of yourself. So yeah, my PhD research for the last 4 years has been looking at the health of Aboriginal children in Western Australia in the context of the child protection system. I'll just give you a brief background to, I guess, this area, and then press on with some of the things that I've been finding. I guess in terms of child removals, so yeah, it's probably common knowledge to many of you that work in this area, but Aboriginal and Torres Strait Islander children are overrepresented in child protection statistics in every single state and territory across Australia. And that's been the way for quite some time. And we know that things that contribute to the risk of being removed, for children being removed, are things like having teenage parents, there being substance use during pregnancy, parents with intellectual disability or poor maternal mental health during pregnancy, and other things that also increase the risk are things like parental experience of out-of-home care for parents themselves that have been in out-of-home care, living in low socioeconomic areas, and systemic racism within the child protection system. And I guess all of these things are kind of attributable to colonization. We're still seeing the consequences of colonization playing out today. Even though the Stolen generations ended, a few decades ago now, we're still seeing the consequences of that playing out, and that being, partly expressed in this significant overrepresentation in child protection statistics. And in terms of health, unfortunately, the Aboriginal and Torres Strait Islander children also have an inequitable burden of disease generally, and they also have higher rates of potentially preventable hospitalizations. And what potentially preventable hospitalizations are, for those of you that aren't familiar with them, is they're basically a category of conditions which could have been prevented. So, say, for example, you go to hospital and you've got gastroenteritis, for example. In theory, if you've been able to access primary care and there'd been maybe social policies and other things in place, instead of having to go to a hospital, you could have been seen in the primary care system. And yeah, these higher rates of hospitalizations and the higher burden of disease generally also attributable to housing conditions. So, for example, overcrowded housing is a big risk factor, especially for potentially preventable hospitalizations. Again, living in low socioeconomic areas, again, systemic racism, and again, linking that back to the consequences of colonization. It's a very brief overview of sort of those two areas. Now, there's a lot of research looking at child protection as it relates to Aboriginal and Torres Strait Islander children. And there's a lot of research looking at the health of Aboriginal and Torres Strait Islander children, but there's not too much that looks at the intersection of those two topics. So what are the health needs of Aboriginal and Torres Strait Islander children that enter out-of-home care? There is some research, and most of the research is either based on sort of regression modeling, looking at how certain factors might be predictive of whether or not children end up going into out-of-home care or being involved with child protective services in some way. And the other side of things is looking at the kinds of specialist referrals. So when children go into out-of-home care, they get a health assessment to understand what their health needs are. And there's quite a few studies looking at what the outcomes of those health assessments are in terms of the specialists that the children end up being referred onto. And most of those tend to be based at individual health clinics, so servicing children in a particular area. There is one study from Victoria that's had a look at referrals at a population level using data linkage, which is what I'll go on to explain in a second. But most of these studies also are comparing the health needs of Aboriginal children that go into out-of-home care to non-Indigenous children. Whereas, I guess what we are interested in here is understanding what the health needs are of the Aboriginal children in WA that are going into out-of-home care and how they compare to other Aboriginal children that don't go into out-of-home care. So I guess an important bit of context for my research is that it was part of the Indigenous Child Removals WA study, or iCare WA. Professor Sandra Eads, principal investigator on that, and I saw there were a few other team members here today. And the objectives of the iCare WA study were part qualitative, part quantitative. I should add a bit to say it's an Indigenous-led project and aiming to understand the views of Aboriginal kinship carers and staff at Aboriginal medical services who have experience with taking care or providing healthcare services to Aboriginal kids that go into out-of-home care. And the quantitative side of things, which is where my research has been based, is looking at some more contemporary statistics on what's happening in Western Australia, because up until this stage, the most sort of contemporary stuff using data linkage was only really until sort of 2010, 2013. Also trying to understand some predictors of out-of-home care. I didn't end up looking at that. And then, describing the health of the children before and after they enter out-of-home care. So what I did, and this is just a brief overview of my thesis, I guess. So, standard intro, literature review methods, and then the 3 chapters here, chapters 3, 4, and 5, are what I'll be presenting on today, the findings of the research that I've been doing. So chapter 3, looking at generating those more contemporary statistics for what's happening within the child protection system in Western Australia. Then chapter 4, having a look at what the prevalence of mental and neurodevelopmental health conditions were, again, comparing kids that go into out-of-home care to those that don't. And then the final chapter there, chapter 5, looking at the rates of potentially preventable hospitalizations and trying to understand a bit more nuance within there. And each of these research objectives was partly informed by the goals of the study, but also from the community reference group and the study advisory group. So I guess one of the things that I've been really mindful of is that I'm not an Indigenous person. And I think it's really important, especially in this space, but I think in all research as it relates to Indigenous people around the world, this concept of nothing about us without us. And I really try to, I guess, listen to the things that are being said in the qualitative research and the conversations that I had within those reference groups to hear what was being said, what the experiences of carers were, and figure out how that could be, how that could translate into a question that we can then interrogate this huge data set we've got, which I'll explain in a second. And my supervisors, so Sandra Eads, already mentioned, Melissa O'Donnell at University of South Australia, Alison Gibbard at University of Melbourne at School of Population and Global Health. Some of you probably know her. And then Koen Simons, who's now at the University of Gothenburg, but was also previously at School of Population and Global Health. So in terms of the data, I already mentioned that it was a data linkage. And for those of you that aren't familiar with data linkage, it's basically a way of getting together multiple disparate data sets and identifying people across those data sets to be able to, just in the case of what we've done, we've got data on hospital admissions, for example, and we've got data on whether or not, on all the children that went into out-of-home care in WA. And what the data linkage branch or data linkage services WA do is they use this probabilistic matching method, which basically goes, okay, what's the first name, last name, date of birth, and maybe some other identifying characteristics of people in data set A and data set B. And if it's above a certain probability, they'll go, these are the same people. And basically doing that, and there's a bit more detail to it, providing us, the researchers at the end, with a bunch of different data sets with a unique identifier for each individual child and their parents and siblings, to be able to link all those data sets together and look at how health varies, for example, for Aboriginal children, depending on whether or not they have contacts with Child Protective Services. So in terms of who is in the data set, it's all Aboriginal children born in WA between 2000 and 2013, including family linkage. So we know who their mum is, who their parents are, there's grandparents and siblings as well. And the data itself covered 2000 to 2019. Just in terms of the data sources, just so you get a sense of what we were using, the birth registrations notification system, so midwife notification system, death registrations, just understanding, when children were born, some of the characteristics of birth. Death registrations was important for some of the work using survival analysis methods, so we could censor them at the appropriate time. Then the child protection and family support data, so that's where all of the information about what kinds of contacts children were having with Child Protective Services came from. Then the rest of the data sets there are sort of health-related data sets, so hospital admissions and then certain registries of different kinds of conditions. So I'll dive straight into it. So this is findings from my first paper, which you can find published online if you want to have a read, looking at the cumulative incidence of child protection system contacts among the cohort that I talked about before. So the two main goals of this study were to have a look at how contacts with Child Protective Services were varying by stage of the child protection system, and I'll explain that in a second, and by birth cohorts. So we use birth cohorts to try and understand changes over time in these contacts. And then the second one was to have a look at how contacts were clustered within sibling groups. So there's been a little bit of research that had a look at how having a sibling that's being placed in out-of-home care affects another child's risk of going to out-of-home care. But that was usually as a covariate and regression model, which provides some information, but it's fairly limited in terms of maybe exploring it a bit more descriptively, looking at maybe the distribution of when these contacts are happening, that sort of stuff. And I guess the other reason why I've looked at this is because one of the things that came up in the qualitative research, the conversations that I would listen to, was a sense that mums often felt that when they had kids taken by Child Protective Services, they felt written off by the child protection system. And that if they had any more children, that those children would be just taken away from them at birth, which is really distressing. And yeah, just made them feel like they weren't given the opportunity to make changes to get their kids back and to stop future removals happening. So that was another reason why I was exploring that second aim there. So for this one, we only looked at data from 2000 to 2015 because we discovered after getting the data linkage that from 2015 onward, it was kind of incomplete. So ended up just using the complete observations that we had. And then the analysis predominantly just plotting cumulative incidence. I think that tells the main story, fairly descriptive methods. And the descriptive methods are good because they tend to be much easier to communicate back to policymakers and the reference group and that sort of thing. Also having a look at just the tabulation of when these placements happened. So this is just the first graph. This is for all kids, not incorporating a time element, just showing the different stages of the child protection system and the cumulative incidence of children who had had a contact. And what's being plotted here is the age at which they had their first contact with Child Protective Services. So the top line there, red line, is when they had a notification, and that could come from anybody really, who might express a concern about the child's well-being. The green line then showing the proportion of children who had who were the subject of an investigation, and then the blue line, the next one down, representing the cases where there was a substantiated case of maltreatment, and then finally the bottom most purple line showing the placements in out-of-home care. And I guess for those of you that maybe aren't familiar with the data set I talked before about there being an overrepresentation of Aboriginal and Torres Strait Islander children in out-of-home care, you can see there that of the cohort that we had, which was about 32,000 children, more than 50% of them had had a notification made to the Child Protective Services about them by the end of our follow-up, which is a big number. Obviously, not all of these children end up being investigated, and in not all cases of investigation, so they actually find cases of maltreatment. But you can see here by age 16 for the cohort that we do have, sort of an estimated sort of 14% were being placed in out-of-home care. So the next panel here is taking those different stages and plotting them in different panels. So stage 1, notification top left, stage 4 on the bottom right is placements in out-of-home care. And the lines are now representing the birth cohorts. So by doing this, we were wanting to have a look at what the cumulative incidence was for these different birth cohorts to see how, well, whether and how contacts were changing over time. And the main trend that you can see in the first 3 panels, it's less obvious with the 4th panel because the proportion is low overall, but it's scaled so you can see them a bit easier, is that the contacts with Child Protective Services were happening at younger and younger ages, the first contacts, I should say. So you can see for the bluish lines, the trajectory, sort of fairly straight, maybe a little bit of an increase around age 0 immediately after birth, but then fairly straight over the course of the follow-up period. Whereas for the red, pink, and orange lines, maybe I can point my pointer here, you can see for investigation, for example, that the line at birth goes straight up. You can see with the 2012 to 13 cohort that 5% of kids were the subject of notification basically at birth, an investigation, sorry. And that same trend is happening at all stages of the child protection system. And in terms of what that means, I think for placements, the proportion or the cumulative incidence of children who had their first placement in out-of-home care by age 1 was about 2% for the kids born in the earliest period, the 2000 to 2001 period, compared to nearly 5% for the 2012 to 13 period. So really demonstrating the real increase in those contacts at birth. I think the other thing that's interesting here is the trajectories after that sort of first year of life are roughly similar. It's that the lines are parallel after that first year of life. It's that increase at birth which is making the big difference here. And I guess the other thing as well is just the shortening lines is just to do with the fact that we've got ever smaller periods to follow up with these children, because the data has a fixed period of time, but we're looking at the age groups of children over time. And the final bit of this paper, and I've got this diagram here to help explain the next couple of results. So what this is meant to be depicting is a mum at the top there, and she's got 4 kids, and the 3 children in green were all born before the first contact with Child Protective Services happened. So, say for example, these 3 kids all born in 2000, 2002, 2003, and the first contact among any of them happened in 2005. But then this blue child was born after that first contact happened, so say 2008. And the first analysis that I'm presenting is just looking at the children who are alive, who had been born by the time the first contact with Child Protective Services happened amongst any of the siblings. And what we're showing here with each stage of the child protection system in this first column, whether or not, and this is only looking at siblings, but groups of children where there's at least one other sibling, because it wouldn't make sense otherwise. So in 65% of cases where there was at least one other sibling, and there was, just focusing on placements, and that one child was placed in out-of-home care, 64% of the time other siblings were also placed in out-of-home care, and their placements all began on the same date. Maybe to put that a bit more plainly, multiple children tend to be removed at the same time. Not deterministically here. You can see within our follow-up period that only the 27% did not have any contact. So were not placed, did not have a substantiation and so on. But in the majority of cases, multiple children were being taken. And I think that is, these children are in potentially, they're in potentially environments where they needs to be an intervention to protect their safety. But I also think about the psychological experience of having multiple of your children taken at the same time is quite distressing. So then going back to this diagram, just to think about the next graph, which is plotting the cumulative incidence of contact for this group of children in the green and these children in the blue. So whether or not they were born before or after that first contact within their sibling group. And it's pretty stark. And I've got the numbers at risk as well, because it's, I think, important to contextualize that the numbers, absolute numbers, are a lot smaller, but the cumulative incidence increases dramatically at birth. You can see within the first few months of life, for kids that were born to mums who previously had children removed, nearly 20% of them have also been removed themselves. And by age 2, that's gone up to 40%. And I think that really highlights that experience that I was hearing in the conversations, that mums felt written off by the child protection system. So that's chapter number 3. Chapter number 4 was then moving on to have a look at what the mental and neurodevelopmental health needs of children were. And I guess the reason why I focused on mental and neurodevelopmental health was, again, because that was something that came up in the conversations and was something that was commonly reported in the qualitative research, that a lot of the conditions that came up were things like autism, fetal alcohol spectrum disorder, kids with anxiety, kids with PTSD. So focusing on those conditions here. So goals were to just estimate the prevalence of these conditions based on whether or not children had had placements in out-of-home care. For some of these conditions, we had a look at the cumulative incidence of when they were being diagnosed, the first diagnosis, and then also having a look at the prevalence of these conditions just for kids that had placements in out-of-home care, depending on when their first placement was. For this particular study, I used matching, which is basically matching children who had placements in out-of-home care to children that didn't have placements in out-of-home care based on these characteristics to try and make the cohort more comparable. So the rationale for that was, especially for year of birth, the proportion of children who never had placements in out-of-home care who were born in the later years was higher than children that did have placements. And that's really relevant because some of these conditions are not possible or harder to diagnose at younger ages. So if you have a cohort of children who on average are younger, you would expect to see a lower prevalence of these conditions anyway. So that's why I've matched on year of birth to make the follow-up times more comparable. So the prevalence estimates are less likely to be affected by follow-up time. And then in terms of how we're doing this, we're combining hospital data, mental health information system data, and some of the registries of specific conditions. So this was finding number 1, and I'll go through these abbreviations in a second. The prevalence estimates for never and ever placed children, way of referring to whether or not they had a placement or not in out-of-home care in that follow-up period. Any intellectual disability, developmental delay, or congenital anomalies. This was about 3 times higher for children that were ever placed in out-of-home care. And it's similar for any mental health conditions. And this is just sort of grouping all mental health conditions together. Again, 15% of children that were ever placed in out-of-home care compared to 5%. Didn't see much of a difference in autism, but we saw out of 10, so the prevalence of FASD was about 10 times higher for kids that did have a placement, and that's fetal alcohol spectrum disorder, and about twice as high for developmental delay. And then in terms of the specific mental health conditions, anxiety about twice as high, depression similar, PTSD about 7 times higher, adjustment disorder higher, and hyperkinetic disorder, which is ADHD, higher as well. But I think with just from going through the submission process and getting reviewer feedback, this is probably an underestimate of ADHD. And that's, I guess, a disadvantage of not having all of the available health data sets to try and identify these conditions. So here we're plotting the cumulative incidence, the blue line being children that were ever placed in out-of-home care, and the red line being children that were never placed in out-of-home care. And this is the cumulative incidence of first diagnosis. And I just want to point out that the y-axis is scaled differently for the different conditions. For fetal alcohol spectrum disorder, you can see that there's a big spike around birth where diagnoses are made, and then sort of increasing to about age 4, and then roughly flattens out there, whereas you can see cumulative incidence relatively low, and that's to be expected given the prevalence estimates for low as well. Developmental delay, you can see diagnoses start happening around age 2, similar for both children, for both groups of children, but just the cumulative incidence and prevalence was higher, which is to be expected. I think the other thing that is interesting here is with PTSD, post-traumatic stress disorder, that the cumulative incidence diagnoses start coming in around age 5 or 6, whereas we don't see any diagnoses coming through for the never placed children until age 12, which, yeah, I guess is just an important thing to think about, that the experiences that the children are having, either the maltreatment that they experience or the process of being removed from their parents, either of those things, I guess, can be contributing to PTSD, and you start seeing it at a much younger age. And then finally, just comparing the prevalence estimates for when children were first placed into out-of-home care. You can see that with fetal alcohol spectrum disorder, it was higher for children that were placed before the age of 1. And I guess if you think about the cause of the fetal alcohol spectrum disorder, that's drinking during pregnancy. That is also a risk factor for having contact with child protective services. And I guess if mums are going in for antenatal care and health professionals who have mandatory reporting requirements are made aware or understand that the mum's been drinking during pregnancy, then yeah, they have a mandatory reporting requirement if they are concerned for that child's welfare to make that report. So that, I guess, is a useful bit of context to understand what might be happening here. And then the other thing that I thought was interesting from here was the difference in PTSD. So still higher than never placed children for those that were placed before the age of 1, but children that were placed after the age of 1 had a slightly higher prevalence of PTSD, and that's potentially through being old enough to form memories of the maltreatment or the experiencing the removal process, but potentially one explanation there for the difference in the prevalence. So finally, then, the last bit of research that I have been working on recently actually was looking at the rates and kinds of potentially preventable hospitalizations. And objective 1, I just have a drink real quick. So yeah, objective 1 was just to estimate what the rates of potentially preventable hospitalizations were based on everyone ever placed status. Then to compare the kinds of conditions, because potentially preventable hospitalizations, if you look at them, there's actually a whole suite of different conditions which are considered potentially preventable. And this was based on the child definition developed by some authors in New Zealand. In Australia, with Australian Institute of Health and Welfare reporting, if you have a look at their reports, they actually report based on the adult definition, which includes a bunch of conditions which aren't relevant for kids. So the conditions that you'll see reported here are more relevant for children. And then to estimate the rate of these hospitalizations for ever placed children before and after they get placed into out-of-home care, to try and understand the effect that being placed has on these conditions. Once children are being placed into out-of-home care, are they then getting better access to healthcare in a primary care setting? I guess that's the question. And I should also point out that the thing that we're looking at is not admissions, it's the number of days spent in hospital, because I guess bed days was, I think, a useful thing to be reporting on, but preempting perhaps a question that when estimating the same things that you'll see in a moment, just using admissions instead of bed days, the incidence rate ratio is basically the same. So again, here we used matching based on this time month and year of birth, and I used exact matching on that because I think follow-up time here, especially because we're using data risk as the denomination, the calculation of these risks, rates rather, important to have much more closely aligned periods of follow-up. And then again, remoteness and socioeconomic status. And those two characteristics are actually based on their mum's socioeconomic area where she lived at the time that that child was born, and again, remoteness area at birth as well. So the way that we did this was looking at the hospitalization data, only looking at those where the primary diagnosis was one of the conditions used to identify potentially preventable hospitalizations. And in the tables, you'll see the rates are expressed in terms of days at risk, per 1,000 days at risk, and then looking at rate ratios. And the modeling you'll see in a second, we used mixed effects modeling with random intercepts. So just looking overall, we've got here age groups, so ages 0 to 4, 5 to 9, 10 to 14, and then just overall for ever and never placed children, the incidence rate per 1,000 days at risk, and then what the incidence rate ratio was. So we can see here that children that are ever placed in out-of-home care have about twice as many days spent in hospital for potentially preventable hospitalization. The other thing I think is important to note here is that the rate itself drops off heavily. When looking at these by individual year, the greatest rate of hospitalization, admissions and bed days is within the first year of life, and it basically just drops off within the first few years and sort of flattens out from about ages, I think 7 or 8 onwards. And you'll see that in a second, as some of the graph. So overall, across all ages, about twice as high, slightly higher, 2.2 in ages 0 to 4, slightly lower, 1.7 in ages 5 to 9, and again, back up to 2.3 in ages 10 to 14. In terms of the conditions, what I've plotted here is the top 10 diagnoses made during those admissions to hospital. And I guess there's 2 things to have a look at here. One is that the proportions are really similar for ever and never placed children. So in terms of like distribution of conditions that are being, the children are being admitted for, very similar. It's just that children who are ever placed in out-of-home care have more of these admissions and more of these bed days. The other thing is, I guess, which conditions are responsible for most of the admissions to hospital. And within ages 0 to 4, they're more respiratory. So we've got acute bronchiolitis, upper respiratory tract infection, asthma in sort of the top. And we've also got gastroenteritis and otitis media, which are ear infections. And then so dental conditions here quite low, but then once you get to ages 5 and 9, obviously once children have actually developed teeth and have teeth to have issues with, and it's not just dental conditions, but you've got issues with health as well. Much higher proportion of these admissions were to do with dental conditions. Otitis media and skin infection is still really high as well. And then having a look at the oldest age group, ages 10 to 14, skin infections, the biggest percentage there, and still seeing dental conditions in the admissions. The next thing I did was have a look at the incidence rate for pre-post first placement in out-of-home care. And I guess this was a bit of a crude way of looking at it. You can see that overall, the incidence rate ratio after children go into out-of-home care is lower by about 0.6 across the age groups than before they go into out-of-home care. So what you might infer from this is that being placed into out-of-home care reduces the rate of bed days, but as I was mentioning before, that age has a really big effect on the rate. So what I ended up doing was also pitching this model, and I laid out this directed cyclic graph just to try and understand how things might be related. Obviously, it's pretty easy to see in Dagger here where I've sourced this from. We didn't have some really important variables here. So culture being a protective factor, information on housing, family domestic violence. Several of these we didn't have data on, so I wasn't able to incorporate them into the model or into the matching. So there's potential unmeasured confounding estimates that I'm going to present in a second, but this is a sort of rough model. So ended up using negative binomial regression, just from having a look at the data, seems to be some over dispersion, incorporating exposure, so everyone ever placed into out-of-home care, pre or post placement into out-of-home care. And I should add here actually that for the 2 children that were never placed in out-of-home care that were matched to the 1 child that was placed, those 2 children were assigned the same date of placement into out-of-home care. Even though they didn't, sort of acting as this counterfactual group for the children that were placed. And then the interaction term to estimate what the effect of placement was. And you'll see here there's 2 different terms for age. Basically, I used multivariate fractional polynomials just to try and check for the continuous variables what the best functional form of them was going to be when fitting this model. And then also remoteness area at birth and socioeconomic area of birth. So the model estimated that placement into out-of-home care on average did reduce the rate of bed days by about 11%. You can see the confidence interval there ranging from 18% to 3%, 3% to 18%. So generally suggesting that there was an effect of being placed into out-of-home care in reducing the rate of these admissions and bed days. What I've got here is a plot of the marginal rates, and this is for the lowest or the most disadvantaged socioeconomic area. And I haven't plotted it in this presentation, but basically increasing socioeconomic area, so getting less disadvantaged and more advantaged, is associated with a mild reduction in these rates. But what I've got here is a plot on average of what the rates are across the 5 different remoteness areas. And what you can see is that going from the major city areas all the way through to the most remote areas, that there's this increasing trend or increasing rate of these hospitalizations or bed days. Now, the orange and yellow lines are indicating the children that were ever placed in out-of-home care. And you can see, again, the effect of age reduces quite heavily, but still indicating there's some effect of placement. I think the other thing that's really important to note here is that the children who were ever placed into out-of-home care don't have, they never reach parity with children that were never placed. Like there's some sort of residual aspect of their health or some other part of their lives or environment that still put in a bit increased risk of having these potentially preventable admissions. And also just plot these by the sort of most common conditions, just to try and see what's happening here. Skin infections kind of followed a similar trajectory going down. Confidence intervals here are much wider because instead of looking at all admissions, we're looking at a very selective set, so numerically smaller, bigger confidence intervals. I think what was interesting was with dental conditions, admissions actually went up, and that's potentially due to there being underlying condition issues with their teeth, and going to out-of-home care actually causes them to seek treatment. And part of that could be that treatment being performed in a hospital setting. I just want to make sure I've got time for questions, so I might just move on from there. Just to summarize, I guess, what I've found across my research. Going back to the first study, that the rates of contact with child protective services are happening at younger ages for the children that were born more recently, and the contacts were clustered within sibling groups, and that the risk of having a contact with child protective services carries over to siblings that are born after that first contact occurs. The prevalence of mental and neurodevelopmental health conditions was 3 times higher for children that were ever placed in out-of-home care, and the prevalence of neurodevelopmental health conditions was about twice as high for children removed before the age of 1 than children removed after the age of 1. And that previous studies, so rates of hospitalizations, both admissions and bed days, were higher for children that were ever placed across all ages, and they never reached parity, as I was saying, with children that were never placed. And the rates for, yeah, so that's put. And then finally, the placement in care has the largest effect on the rate of these hospitalizations in the first few years of life. I guess implications of this, the parents who've had children removed, I think they need more support. And if you think about one of the challenges of delivering an intervention is you need to be able to identify the group of people that need that intervention. But Child Protective Services know who these people are because they've already removed the children. So we know that they're at risk of having children removed in the future. So if we're able to identify ways that they can be supported, then hopefully we can help them work towards reunification and prevent future removals. And I think this support needs to be, I guess, holistic, because there's a lot of different factors that go into increasing the risk of these children being removed. Housing, for example, parental mental health, like there's a lot of different avenues that need to be addressed to be able to, I think, bring that rate down. The support also needs to be culturally safe. I think that's a really big factor. There's one of the studies that I think had the biggest impact on me when I was reading it was one reporting on the experiences of Indigenous parents with Child Protective Services. And one of the stories was someone had reached out to, it's called Child Protection and Family Support, right? So they'd reached out to the department to try and get some support so they could buy their child a new bed because their kid needed a new bed. But what instead happened was their child got removed. And I think that's a real, I think there's very little trust of Child Protective Services. So whether or not Child Protective Services as a whole can be made culturally safe, or if service delivery and I guess the responsibility of ensuring child welfare is assigned to a separate organisation, like in Victoria, where VACA have the Victorian Aboriginal Childcare Association, have that responsibility, potentially providing a more culturally safe way of ensuring safety of children. There is a policy within child protection within WA to have Aboriginal caseworkers, but I think one of the things we heard was that the rate of burnout was quite high because there weren't enough staff to handle the caseload. That you'd have caseworkers with really high numbers of cases and ultimately leading to burnout and not enough oversight over that process. There's also been this policy of Aboriginal family-led decision-making, which is where family and elders get to have more input on the decision-making process when it affects their children to ensure that, I guess, there's a better cultural understanding and the decisions made are more appropriate. In terms of the health implications, we've seen, I've demonstrated that the health needs are greater, and that quite often as well, the children that do go into out-of-home care have multiple and complex health needs, and that's really evident in the studies I was talking about at the beginning, which have looked at the specialist referrals that the kids need when they get that screening going into out-of-home care. I think the capacity of the public healthcare system is a big issue, and I think it's a big issue for everybody, but the children that are going to out-of-home care tend to be more from lower socioeconomic areas. And, we need to increase the availability of affordable general practice. And I think that comes through from, obviously, federal government manages Medicare rebates and that kind of thing. But also there needs to be more staff. One of the big issues is that for specialist care in particular, that there is a really long wait list to get access to pediatrics and developmental pediatricians. We're talking potentially longer than a year, which the sooner children can get diagnoses for the conditions they have, the sooner they're going to be able to get the care and support that they need, and the carers as well, or parents who are taking care of those kids. The other thing as well is there needs to be an increase in culturally competent medical professionals, because it's not just a case of increasing the number of professionals, they also need to be able to deliver healthcare services in a way which isn't stigmatizing parents and children, Aboriginal parents and children. In terms of reducing the risks of these hospitalizations, because these potentially preventable hospitalizations are kind of a metric for how well a health system is performing. I think one of the big issues is housing. And if you have a look at some of the conditions that are identified, so used to identify potentially preventable hospitalizations, housing conditions play a big role. So reducing, I guess, improving housing standards, reducing levels of overcrowding, I think are going to be important. But the other thing is access and availability of healthcare. So the health performance framework that the WA government publishes, looking at, I guess, how Aboriginal and Torres Strait Islander people in WA have been utilising the healthcare system, in interviewing people that have come through to the emergency department with a condition that could have been seen in a primary care setting. Things like access to transport and distance were a big issue in not seeking healthcare before it became an emergency. The wait time, even just for general practice, are an issue, and the cost as well. And, when there's fewer and fewer practices which are only bulk billing and they're including gap fees, deferring healthcare when it's not affordable is going to, result in increased potentially preventable hospitalizations. In terms of what my research contributes, it addresses a research gap. It's explicitly identified in the Australian Institute of Health and Welfare's reporting, providing information on the health needs of these children and the difficulties that their parents and carers might be having in terms of accessing timely and appropriate healthcare. I've got this quote, "We already knew this," because that was some of the feedback that I got in discussions with the Department of Staff, Department of Communities. And, it's really great that they already know it, but having internal information available is very different to having information available in an open access publication that can be used for advocacy, and that kind of thing. And yeah, just quantifying some of those intersections between child protection and health. And in doing all this, I've been really trying to prioritize Aboriginal voices in this research process, listening to things said and implementing that. And then I think for future research, I think disaggregation by region, because this is just at a population level for the entirety of WA, which is enormous, it's a third of Australia's geographic area. I think providing locally relevant statistics would be useful. I think building on the director's cyclic graph and including broader data sets to have better control of confounders, maybe estimating effects of policy changes. And I won't go into informal care nearly at time. And just a quick summary of what I've been doing. There's been regular translational workshops throughout the iCare WA study. I did a presentation to New South Wales. I think it's like a community of practice for staff at child protection service there. About 450 people turned up, which was insane. I've never presented to that many people. And I've got another similar presentation with WA in a couple of months. Presented at an international conference. I've been developing graphics and open access publications, and just standard acknowledgement. Just thanks to my supervisory team, the PhD cohort who I've done my PhD with, my family and friends, and the community reference group. And that's it. Thank you.